There are 5 joint surgeries that, if my own doctor recommended them to me at 62 years old, without doing a few specific things first, I would politely thank them, walk out of the office, and ask for a second opinion that afternoon. I want to say something carefully at the very start because this is sensitive ground. Surgery is a tool. For some people, at some stages, it is the right tool. Many of the orthopedic surgeons I have known across 30 years of clinical observation are excellent at what they do, and the operations performed in current orthopedic practice have given thousands of people their lives back. What I am about to share is not a campaign against surgery. It is a list of 5 specific procedures where the published evidence, as of today, suggests that a serious conservative trial should be attempted first, and where case after case I have seen documented showed the patient walking out without needing the operation they had been told they needed. Quick disclaimer before we go further. This is educational content, not medical advice. I am Dr. James Whitaker, a composite educational character built from 30 years of represented physical therapy experience. Nothing in this video should be interpreted as a directive to cancel a scheduled surgery. The right way to use this information is to bring it to your own physical therapist, your own orthopedic surgeon, or your own physician, and have a real conversation about whether a 12-week conservative trial is reasonable for your specific case. If you have recent surgery, severe osteoporosis, an acute injury, or significant balance impairment, please work with a hands-on clinician before changing anything about your treatment plan. Now the 5. Surgery number 1. Arthroscopic meniscus debridement, sometimes called arthroscopic partial meniscectomy, performed for degenerative meniscus tears in adults over 50. This is the surgery where a surgeon goes in with a small camera and trims the frayed edges of the cushion inside the knee. For decades, it was one of the most commonly performed orthopedic procedures in the world. Then in 2013, a landmark study published in the New England Journal of Medicine, led by Sivonen and colleagues in Finland, randomized 146 patients with degenerative meniscus tears to either arthroscopic surgery or a sham operation, where the patient was wheeled into the operating theater and given the same incisions but no actual surgical work. At 1 year, there was no meaningful difference in pain or function between the two groups. None. A 2017 BMJ Clinical Practice Guideline panel reviewed the full body of evidence and issued a strong recommendation against this surgery for nearly all middle-aged adults with knee pain. Case after case I have seen documented had been told they needed this operation. The truthful conservative alternative is 12 weeks of progressive strengthening for the quadriceps and the hip stabilizers, combined with movement retraining. In the clinical pattern observed, and supported by the cited evidence, the great majority of patients regained function without operating. The conversation to bring to your surgeon is this. Ask them whether a 12-week strengthening trial is reasonable before scheduling the arthroscopy. That is the question. There is one more thing worth saying about the meniscus debridement. Some patients in the cases I have reviewed reported a brief improvement after the surgery, lasting 2 or 3 months, before the pain returned. That brief improvement is real, but it is not what most people think it is. It is partly the placebo effect of having had something done. It is partly the rest that the patient took during the recovery period, during which the inflamed knee finally calmed down. And it is partly the post-operative physical therapy that almost every surgeon prescribes after the operation. The strengthening done in those weeks of post-op rehab is often the same strengthening that would have worked without the operation in the first place. The lesson is not that the operation never helps. The lesson is that the help came largely from the rehabilitation, not the trimming. Surgery number 2. A routine series of cortisone injections for chronic knee or shoulder osteoarthritis, given as the default first or second treatment without a real strengthening attempt. Now, cortisone is not technically a surgery, but I am including it here because patients often perceive it as a quick fix that defers thinking about the alternatives, and because the research on long-term cortisone has shifted dramatically in the last 7 years. A 2017 study in the Journal of the American Medical Association by McAlinden and colleagues randomized 140 patients with knee osteoarthritis to 2 years of cortisone injections or saline placebo injections every 12 weeks. The cortisone group had measurably greater cartilage loss on MRI at 2 years, with no meaningful pain advantage over placebo. Greater cartilage loss from the injections that were supposed to help. That does not mean cortisone is always wrong. A single targeted injection to break a flare so a patient can engage with rehabilitation can be reasonable. The problem is the routine series, the every 3 months injection that becomes the entire treatment plan. The conservative alternative is the same as for the meniscus debridement. 12 weeks of supervised progressive loading, with the cortisone reserved as a one-off bridge if it is needed at all. Ask your doctor whether the 12-week trial is on the table before the 3rd or 4th injection. Let me pause here for a moment. I want to remind you again, I am not telling you to cancel a treatment your doctor recommended. I am telling you to ask one question. Can we do 12 weeks of structured strengthening before the next step? If the answer is yes, you have lost nothing but 3 months. If the answer is no, ask why. The answer to that why is often the most useful piece of information you will get all year. Surgery number 3. Partial knee replacement, or in some cases full knee replacement, performed in adults over 60 who still have substantial cartilage on imaging and who have not completed a structured rehabilitation program. The evidence here is more nuanced than the first two, because knee replacement is one of the most successful orthopedic operations ever invented for the right patient. The problem is overuse. A 2014 study in arthritis and rheumatology, looking at over 200,000 U.S. knee replacements, estimated that roughly 1 in 3 was performed on a knee that did not meet the appropriateness criteria for the operation. 1 in 3. Case after case I have seen documented had been told the knee was bone on bone and that a replacement was inevitable. When the imaging was reviewed, the cartilage was thinned but present. When the strength was tested, the quadriceps was profoundly weak and the hip stabilizers were sleeping. 12 weeks of progressive strengthening, in 9 cases out of 10, dropped the pain enough that the patient chose to delay the operation. Sometimes the delay was permanent. Sometimes the operation was eventually performed 5 or 7 years later, and the patient was grateful for those 5 or 7 years on their own knee. The conversation to bring to the orthopedic surgeon is this. Ask them what the cartilage thickness looks like on imaging. Ask them whether your quadriceps strength has been measured, and ask them whether a documented 12-week strengthening trial has been completed. If any of those answers is no, you have a reasonable case for delaying the operation while those gaps are filled in. Surgery number 4. Spinal fusion for non-radicular low back pain, meaning back pain without clear nerve compression causing pain to shoot down the leg. Spinal fusion is a major operation. It permanently joins 2 or more vertebrae, removing the motion between them. For patients with severe instability, fractures, infections, tumors, or progressive deformity, fusion is sometimes the right call. For garden variety back pain in adults over 50, the evidence is much less supportive. A 2014 review in the Journal of the American Medical Association, summarizing several randomized trials, found that for nonspecific chronic low back pain, fusion offered modest improvements over conservative care, but with substantially higher complication rates and longer recovery times. A 2019 BMJ paper noted that the rate of spinal fusion in the United States had roughly doubled in 15 years, without a corresponding doubling of the underlying conditions that warrant it. The conservative alternative is a structured core and hip program with a hands-on physical therapist who can assess the lumbar spine in person, alongside a movement-based pain strategy. Ask your surgeon whether the documented conservative trial has been completed before the fusion is scheduled. If the back pain is non-radicular and not coming with progressive weakness or loss of bowel or bladder control, 12 weeks of structured rehabilitation is a reasonable ask. A note specifically for adults over 60 considering a knee replacement. The expected lifespan of a replaced knee is roughly 15 to 20 years for most modern implants. If you have a replacement at 62 and you live to 85, there is a real possibility you will need a revision surgery in your late 70s or early 80s. Revisions are considerably more difficult than primary replacements, with higher complication rates and longer recoveries. Every year you can responsibly delay the original operation is a year shaved off the probability of needing a revision later. That is another reason why the 12-week conservative trial is worth taking seriously, even if you ultimately decide to proceed. Surgery number 5. Rotator cuff repair for moderate, long-standing, non-traumatic tears in adults over 60, performed without a serious attempt at structured rehabilitation first. The rotator cuff is the small set of muscles that holds the ball of the shoulder in its socket. Tears in the rotator cuff are common in adults over 60, often present on imaging even in shoulders that feel completely fine. A 2014 study by Kukkonen and colleagues, published in the Journal of Shoulder and Elbow Surgery, randomized adults with degenerative rotator cuff tears to either surgical repair or structured physiotherapy alone. At 1-year follow-up, there was no clinically meaningful difference in pain or function. At 2-year follow-up, still no clinically meaningful difference. A 2020 review in BMJ Open confirmed the pattern for moderate non-traumatic tears. The conservative alternative is 12 to 16 weeks of progressive shoulder loading, with attention to the scapular stabilizers, the posterior cuff, and the thoracic spine mobility. Case after case I have seen documented for shoulder pain regained function through that program without ever having the repair performed. Ask your surgeon whether your tear is traumatic or degenerative. Ask whether a documented 16-week loading program has been attempted. If the tear is non-traumatic and the trial has not been done, you have a reasonable basis for asking for the trial first. Let me pause again. I have given you 5 surgeries and 1 consistent ask. 12 weeks of structured strengthening, supervised where possible, before the operation. That is the single most useful sentence you can take into your next orthopedic appointment. It is not aggressive. It is not adversarial. It is the question every conservative first guideline now recommends asking, and the surgeons I respect most are the ones who welcome it. There are 2 composite patients I want to mention before we close. The first was Walter, 68, a retired electrician with a degenerative meniscus tear and a knee that had been told it needed arthroscopy. Walter completed the 12-week strengthening trial. His pain dropped from a 6 to a 1, and 4 years later he is hiking with his grandchildren without ever having had the operation. The second was a former dance teacher named Cordelia, 70, with a moderate rotator cuff tear and a recommended repair. 16 weeks of structured loading, and she went back to demonstrating in class. The shoulder is still imperfect on imaging. The function is excellent in life. The operation has not been needed. There is a thread that runs through all 5 of these operations, and it is worth saying plainly. In the great majority of cases I have reviewed, the patient had never been offered a structured 12-week strengthening trial as a real first-line option. They had been offered a brief course of generic exercises, often a pamphlet, sometimes a short series of physical therapy visits, with no progressive loading and no documentation of strength gains. That is not a real conservative trial. A real conservative trial is 12 to 16 weeks of supervised progressive resistance training, with measurable strength milestones and documented pain scores at the start and at the end. If that has not been attempted, the question of whether the operation is necessary has not really been asked yet. The orthopedic guidelines now agree with that framing. Many surgeons agree with it in private conversation. The system has not always caught up. Here is the line I want you to remember because it is the legal safe line that protects both you and your relationship with your surgeon. Tell them, I want to do a 12-week conservative trial first. If at the end of those 12 weeks I have not improved, we can revisit the operation with better data on the table. That is the conversation. Bring this protocol with you. Talk to your physical therapist or physician. The decision is yours and theirs together, never mine from a screen. If you do nothing else from this video, write down that one sentence on a piece of paper and bring it to your next appointment. 12 weeks, conservative trial, first. That is the sentence. Tell me in the comments which of the 5 surgeries was one you or someone you love had been recommended. I read every comment, and the patterns I learn from your replies inform what I teach in the next video. This was educational, not medical advice. Talk to your physical therapist or physician. Bring this with you, and take care of your joints, your family, and the time you have on your own feet. One final point that I want to put on the record very clearly. If your surgeon has examined you in person, reviewed your imaging, completed a thorough conservative trial, and arrived at the conclusion that surgery is the right next step for your specific case, that recommendation deserves serious weight. Surgeons have a kind of information I cannot have from a screen. Some of you watching this will be in that situation, and the right answer for you will be to proceed. The purpose of this video is not to second-guess that decision. The purpose is to make sure the conservative trial was actually done first, so that the decision in front of you is being made with complete information and not by default. Until next time, move well, stay strong, ask the question, and do not let the most important decision about your own joints be made without the strengthening trial on the table. Bring the question with you. The surgeons worth working with will respect you for asking it.